or we actually going to have some mitigation and consequence management in place to ensure that, our healthcare system is in tatters, and I'm sorry, I'm going to say it as it is. The reality is that healthcare is failing the citizens of this country, and we got so many issues that we need to actually deal with when it comes to upgrade of facilities, when it comes to shortage of staff, when it comes to shortage of equipment. And here we've got billions of money spent, which could have easily been spent on, upgrading our facilities, allocating more staff. We've got comm service doctors that are sitting at home that are waiting. I mean, every hospital that we've done oversight to has told us that, due to the extra hands that was on hand due to COVID, they're really feeling the shortage of staff even more now. And all this money could have been easily budgeted to pay for the extras necessary on the ground. So I also want to find out is, can the department provide an updated information regarding adverse events following immunization, the AAFIs? How many cases were reported thus far and their severity? How many people actually applied for the no-fault compensation fund? How many were rejected and on what basis? And how many are valid? I'm talking about current numbers. And how many claims have been finalized and paid out? And if not, what are the delays in this matter? COVID-19 has had a major impact on TB testing and treatment, and we know TB is a silent killer in this country. How is the department going to address these shortcomings and catch up with TB testing throughout the country? I'm going to touch on again, because I think it's very important. On the 13th of June this year, the World Bank approved, of 454.4 million euros alone. This because, South Africa's COVID-19 emergency project plan or response project plan needed to be addressed. And this loan came following a request by the government for assistance in financing vaccine procurement complex. Now, we know that government's response to the COVID pandemic has been marred by corruption and mismanagement, which costed lives. Now, these failures obviously include the 80 million rand digital vibes corruption scandal, which implicated the former Minister of Health, Dr. Zweli Mkhize, as well as the PPE corruption. Really, all these issues that we're talking about today is a serious indictment on the Department of Health. I'm sorry, Chair, I need to say what I need to say. With regard to monkeypox, on COVID-19 vaccine procurement, South Africa and other African countries, often had to play.
Just be mindful that as many questions as you ask, you're going to need responses. We're going to be left with less than 1 hour to receive responses. Some of the questions which we raise here can be sent to the minister in either for written reply or oral reply. I'm not stopping you necessarily, but I'm bringing all of you to understand we are not going to get all your questions answered today because of the number of questions raised.
Chair, I hear you and I acknowledge what you are saying, but I think we need to also remind all of us on this platform, we've been practically begging for the minister to come to our portfolio committee. I think if we can just take away the fixation of the NHI, we can actually address other matters of importance affecting the healthcare sector in this country. So I hear you, Chair, and with due respect to you and my colleagues, I fully understand what you are saying, but we really need a meeting with the minister at least once a month, so that we don't have this influx of information that we actually need clarity from the minister and the department. I'll try to run through my questions quickly, Chair. So on COVID-19 vaccine procurement, South Africa and other African countries often had to play second fiddle to developed countries in the race to secure adequate vaccine supply for their populations. Now, given the frequency with which diseases are being reported across the globe, how effective are South Africa's disease surveillance and mitigation systems in identifying and containing these outbreaks before they reach our shores and infect a local population? And with regard to monkeypox as well, are they, is the country ready, especially also considering if isolation is necessary, are the facilities prepared in cases where and if these are necessary? Developed countries for vaccines or medication in the future. And I really want to know, what is the department actually learned from the COVID-19 pandemic and how we dealt with it? And maybe some of us will say that we dealt with it very effectively, but if you're listening to all our questions today, obviously we have issues that needed to be raised, and we can see there's serious mismanagement of funds and consequence management need to be still addressed to us. How is this going to be managed? The health regulations update, why are these regulations actually still needed given the diminishing impact of COVID-19? And will we obviously be provided with the amount of objections received by the department with regard to these regulations? The backlog of surgeries, oh God, this is so very concerning, you know. I've asked questions, I noted the
I don't
figures
want
from...
to be a policeman, but I think you're being unfair.
Chair, just 2
Write
minutes,
some
please.
of
I'll be
these
now
questions
finished.
to the minister, because you're not going to get all the answers today. We will have less than 1 hour left. We have 3 members who must still raise questions. 4 members who still want to raise questions to the minister.
Chair, 1 minute.
You're already
Chair,
at question 20.
Chair, 1 minute.
They're going to answer that.
With regard to the serious backlogs of surgeries, I've been inundated with emails where patients are crying, or family members of patients are crying that people have been turned away and they've been on the waiting list. Chair, we're really getting different types of replies from various of our questions to the minister. I ask questions, I've got one reply. Honorable Van Staden got a different reply. The EFF got a different reply. I've got all the states in front of me. Seriously, we're not getting authentic replies from the minister and his department with regard to these backlogs. Thank you, Chair. I will leave it at that.
Thank you. And just a correction, Honorable Ismail. Legislation in black and white according to our work is the main focus of our work. What we're doing here is bringing the minister, as you correctly say, so that he could answer certain questions. But we have many avenues in which we can ask questions to the minister and the department. Let's use all of those other avenues too. Thank you very much. Honorable Sheikh Imam.
Thank you very much, Chairperson. I've just been attending some other meetings simultaneously, but thank you very much for the presentation. I think we must admit that whilst a lot of good work is being done, that's overpowered by the fact that we have serious challenges in the healthcare sector in the country. You know, I'm not sure why the department appears to be defending themselves. If you look at Baragwanath alone, there has been report of almost 11,000 surgical procedures that are being delayed for a considerable period of time. And some of, some of the reasons that are being given, non-availability of clean linen. Can you imagine maintenance of the equipment and things, Can you imagine patients running out of food in these government institutions? And we think it's business as usual. Really, I think we have a problem. Now, the question that arises, Chairperson, whilst I am a fully behind the national health insurance, given the state of healthcare in South Africa, do we really believe we're going to make a success of this NHI? More and more medical experts in this country, medical practitioners, healthcare workers are leaving the country. We already have a massive shortage, particularly in rural towns, and more of the people are leaving. I don't know how we actually, government is going to be, or the department is going to particularly deal with this. Patients are being turned away from hospitals. Time and time again, you find patients are being turned away, and some of them actually die. Medical claims are on the increase in government hospitals. Not that we're not having that in the private sector. Yes, we are. But more importantly, I think in the public sector, we seem to be having a serious problem. The waiting period appears to be very, very long for some people. I mean, they've been turned away on the basis that we cannot, you have a long waiting list because you have limited human resource, particularly to be able to perform some of these surgeries and give attention to some of these people. So, I don't know, Chairperson. It seems like we need a miracle in this country because, there's not a single department that seems to be working effectively. And when you talk about healthcare, particularly in this country and the quality of healthcare, we have an added problem. You don't have enough staff, but you've got staff that are moonlighting from private sector to public sector. So I don't know whether the department has what it takes, Chairperson. Maybe the minister is going to explain to us what additional measures. Can you imagine when you hear this horrifying news that now even because of no energy, children in incubators have a problem. Children are dying because we don't have energy supply. Yes, I know the minister did allude to the fact that there is generators and things, but that's not a true reflection of exactly what is happening on the ground. There is also no consequence managers, people that are failing this government institutions, these hospitals and things, still keep their jobs year in and year out. They don't have maintained the equipment, they don't have medicine on time, they're not able to provide the service, but the jobs are still there. So I don't know, maybe the minister needs to tell us. I don't want to say much more, I've got a whole list of them, Chair, but I think colleagues have alluded to that. But let's give the minister and his department an opportunity to tell us how can we sit down and find, and it's not only their problem, Chairperson, let us be honest. This is a problem they also inheriting. It's a national problem with everything that we have in the country. How can we assist them? How can we improve the quality? How can we protect our people? Maybe they should tell us. And then lastly, on the issue of side effects, particularly on the vaccines that were given, I'd like them to give us a report on that as to what is the numbers of side effects, what claims have been processed and paid to date, how severe has these side effects been, and what percentage of people were affected in the country. Thank you, Chairperson.
Thank you, Honorable Munyai. I know you.
Thank you very much. Thank you very much indeed. I would appreciate to welcome the report by the minister and the team. There's no government that worked very hard and really saved the life of the people, even during the pandemic, COVID-19 pandemic, than the African National Congress government, led by the minister, Pasa, and the team. So we have to appreciate that COVID-19 has brought the unprecedented consequences, the challenges that we did not expect. So therefore, the minister comes here before us and say there's this issue that arises from the treasury. The money has been saving the life of our people. So therefore, Honorable Chair, we must appreciate the report by the minister and who come open and clean before this August House or the Portfolio Committee to share with us what are the potential challenges arising from the audit report. So therefore, we should welcome that report with open hands. So we must also appreciate the minister to give us some updates so far as the monkeypox is concerned and any other issues that we've seen before. So therefore, Honorable Chair, let's appreciate the report and support the efforts of the ministry taking forward to protect our people. The same way that we fought various pandemics before, we will fight and succeed against the monkeypox. So it is the ANC view that we should support the minister and to move forward to save the people of South Africa. And the minister that put everything open to bear, to say that we have a backlog of the procedural surgical work across the provinces. And that work has been disrupted equally by the COVID-19 pandemic. So therefore, the minister and the team, we thank you for coming before us and update us. We thank you for taking progressive efforts to save the life of every South African and for cautioning us that about the COVID-19 pandemic so that we should be alert. We know that you are working very hard with your team to serve the interests of the Republic of South Africa. The ANC thank all the health workers, thank the team that work with the ministry and the deputy minister to fight side by side with the health workers to succeed in saving this country. All these challenges are noted. We'll continue to call the various MECs from various provinces to come and account before this Parliament Portfolio Committee to tell us what mechanism and the program they have to expedite the work with regard to surgical work and medical procedure in that regard. On behalf of the ANC, Honorable Chair, we are very excited and we stand by our leaders from the National Department of Health. Thank you very much indeed.
Thank you. Honorable Chirwa, I see you lowered your hand.
Thank you. Oh, no, I didn't lower my hand. Probably from the previous engagement, but my hand is still up because you noted me as well. These are my questions. Greetings to all the colleagues that are present on the platform. My first question is this: the Department of Health is currently vaccinating people with mRNA and vector COVID-19 vaccines. On the 31st of January 2022, SAPRA approved inactivated COVID vaccines subsequent to the inquiries that were being made on the availability of Sinopharm vaccine in particular, right, at the vaccination sites. We are now having people who should have vaccinated, but because the government has not made their vaccine of choice available, despite the fact that the call was supported across all political parties for a bouquet of vaccines to be available, even by the president of the country, to be quite frank. And despite the fact that Sinopharm was approved by SAPRA, it's still not something that the department is acquiring to be available in the public sector. What is the department doing to ensure that the inactivated COVID-19 vaccine is included in the national vaccination program? And why hasn't it been included in the national vaccination program? I'm asking this because when we initially asked this question, the reason was that it was not yet approved. And now that it is, why is this still the case? How is it that, number two, how is it that the 2022 shipment of Pfizer is noted as the last contractual shipment when the department is expecting 20 million more doses from Pfizer? This information we get from your own people inside who have reported to us anonymously, or not even anonymously, but have asked that we keep their identity kept, right? Who are also concerned about the department's bias in favor of Pfizer and Bill Gates vaccines. You're about to administer these vaccines to children, despite the fact that Pfizer hasn't reached the necessary standards for this to happen. Meaning basically that the department is buying or is planning to buy Pfizer vaccines for children when Pfizer hasn't even presented the standards required and is still undergoing that process. Why are we not being appraised of these plans by the department when they are dealing with the issue of vaccination? And also about the extra effort by the department to buy Pfizer and J&J, even when there's other options available that are also approved. Who doesn't benefit that we don't receive this information as a portfolio committee of health? More so as it is a norm to report even future agreements or even future plans, both estimated, contracted, and aspired plans regarding vaccination. Why, number three, why are we still buying vaccines in this magnitude, as I've stated above, when the demand has reduced? Is there an agreement that we don't know about between our government and J&J, Bill Gates and Pfizer, that's forcing you to keep buying vaccines that are going to expire, as you are saying, as per your assertion, and you'll be unable to sell them because nobody wants to buy them because the demand has went down? What informs the stipulated waiting periods that are stated? Okay, before I even come into this,
have we lost you, Honorable Chirwa? Honorable Chirwa? It seems like we'd lost Honorable Chirwa. Thank you, members, for all of the questions you had raised. It's now 5 minutes past 12. Remember that our meeting will end at 1300 hours. I have a couple of points I want to raise with the Minister and the department. The one is I had given input on the good work that the department had done, and also the vaccination rate which we had been able to achieve, as well as the low infection rate at the moment. Well, I also note that the department is focusing on ongoing demand generation, and they speak specifically about strengthening the use of data, especially the geographic information system.
Chairperson, was I not on the floor?
Yes, but you were lost. You were cut off somewhere, so I thought you were gone, Honorable Chirwa.
Oh,
I will
no,
hand back to you now. I will give you the opportunity now. I will then stop and allow you to continue. Thank you.
All right. I don't know where last did you guys get me, because I'm a bit confused because I've been rambling on and on. I wasn't aware that you could no longer hear me.
I'm not certain exactly, because it is sometimes difficult to understand, as you say, when you're rambling on and on. So I think probably around maybe your
okay, never mind. If you're not listening as a chairperson, it's fine. You can keep quiet. I'll continue.
Just continue.
If you're not listening as a chairperson to provide guidance, I don't know what you're doing, but I'll continue nonetheless. Number two, I'll start from number two. How is it that the 2022 shipment of Pfizer is noted as the last contractual shipment when the department is expecting 20 million more doses from Pfizer? This information we find from your people inside, who are also concerned about the department's bias in favor of Pfizer and Bill Gates vaccines. And these vaccines are about to administer to children, regardless of the fact that Pfizer hasn't reached the necessary standards for this to happen. Meaning, basically, that the department bought Pfizer vaccines for children when Pfizer hasn't even presented the standards required and is still undergoing that process? Why are we not being appraised of these plans by the department and the extra effort to buy Pfizer even when there's other options available? Who does it benefit that we don't receive that information as a committee? Who does it benefit that Sinopharm is approved, but you're not buying it, but you keep on buying Pfizer and J&J, regardless that they expire? More so as it's a norm to report even on future agreements, both estimated, contracted, and aspired agreements or aspirations regarding the department and the vaccination program. Why are we not being given this information? It actually finalizes or actually confirms our suspicion that the health department is captured by Bill Gates, which is a problem. And number three, why are you still buying vaccines in this magnitude when the demand has reduced? Is there an agreement you don't know about between our government and J&J and Bill Gates and Pfizer that's forcing you to keep buying vaccines that are going to expire and, as per your assertion yourselves, will be unable to sell because nobody wants to buy them? And then on the surgical backlog issue, what informs the stipulated waiting periods that are stated there for surgeries? And when will these waiting periods be reduced systemically? Because I think it's quite embarrassing that the department is coming to us and telling us that written in paper that people have to allow themselves or have to accept the fact that they'll have to wait for 7 years to get hip replacements. This is an overt admission of failure. If you can't give people healthcare as per need, what are you still doing as a Minister of Health if you can't provide health services for our people, if you can't lead us in that direction? You are telling us about all these things, specialist tours, and they're not the thing we should be proud of, in fact, because they highlight shortage of healthcare workers and specialized healthcare workers. What's the intervention plan in that direction regarding surgery backlogs, regarding the issue of dealing with specialist shortages in our institutions of healthcare facilities? And lastly, in the Tembisa hospital corruption, what has the department done? What interventions has the minister put in place in light of the happenings at Tembisa Hospital? Thank you.
Thank you very much, Honorable Chirwa. Honorable Minister, I was still asking you about the geographic information system and your ongoing demand generation. So the question I had was, what were you planning to do with the systems in the future, and how do you think you're going to maintain the integrity of these information systems, and what would be the roles of those systems? Because surely we're going to always have new challenges in the future as part of the challenges which we're also having now. And then in terms of your strategies to mitigate the delivery of the vaccines, J&J vaccines, and other strategies to mitigate the cost or to lower the cost of the vaccines, I think that's quite commendable, and I would hope that you have great success in saving us money on those challenges. We also understand that at the time when these negotiations were made, it was a very challenging time in terms of the global market and the demands which were placed on governments and departments in terms of the procurement of the vaccine. So that fallout is in a manner quite understandable too. Now, I want to speak maybe just on two other items. The one is on the surgical operation backlogs. We understand that monkeypox is a particular clinical diagnosis, and it purely, and this is to answer Honorable Wilson, it's made on the presentation of the patient. And there's no way that a doctor who is trained would not be able to diagnose chickenpox just at a glance. I think I mustn't confuse these two issues, really. And also that monkeypox in itself is, there are a lot of reasons it's been explained to, and maybe it's a good thing to go and read, but not to question the doctors on their clinical ability to make particular diagnoses. And then, considering the surgical backlogs, operations backlogs, yes, it is quite difficult to see and to fathom that we hear that the plan to address these challenges between the 2-week and 7-year program And if we look at the type of operations which are required by patients, then surely there must be a more urgent means and way to be able to address this. And the way to address it, of course, is one, the patient's availability, which was spoken to, the availability of the necessary personnel to be able to perform the operations, and the facility that is then required to be able to perform those operations. So, and then, of course, this problem now of load shedding, which adds to it. But the point that is raised there is that emergency cases are taken into consideration, but there is no, it's not mentioned whether these would the extrapolation of understanding of the time frame doesn't seem to mention new cases. So when new cases, of course, come about which are more urgent and not necessarily an emergency case, then surely these cases would then take longer than these. So there needs to be particular plans to alleviate this. That brings to me to just the people who must do the work, the specialists. We see provinces say they're going to recruit specialists. There aren't many specialists to be recruited because they just don't exist in our country. And then secondly, this problem of registrar posts, Minister, which have been reduced to, I think, probably a quarter or to about 20% of what we used to have before. It's something that needs to be addressed very, very urgently, understanding that it's a provincial competency, but I think there needs to be an intervention from a national department's view to be able to increase those numbers expediently. We understand, those of us who are medically trained understand the role that registrars, medical officers play, and even your community service doctors in terms of the alleviation of the work, being able to perform different operations at different levels of care. And so that has always been a part of the performance of operations that's been done by registrars under the supervision of the specialists. But if we can increase those number of registrar posts, it would surely do a lot. And then also in terms of the medical officer posts, we need to really look at increasing those. And the other question, which I have spoken to you at some time about, is this position of 2 years internship and a year community service for the newly medical graduates. That is something that we really need an urgent intervention on, because surely in terms of the numbers, and the plan was to increase the numbers of doctors who were available to perform work, especially in the rural areas, but in all areas of South Africa. And we seem to have reached that peak in terms of our interns and our community service doctors. Then there was a position paper which I know was also discussed, and I actually like the position that is taken by the Family Physicians Association of South Africa, where they advocating for a family physician in every district hospital. I think that will go a long way to address this problem of operation backlogs, because many operations can be performed by those specialists who are specially trained for that purpose, and we also need to look at that possibility. And then in terms of load shedding, the question that was always raised is, why can hospitals and medical facilities not be exempted from load shedding? I've just seen that 10 facilities in the Greater Johannesburg will be, City Power has just announced that they will exempt 10 facilities from load shedding, which is very commendable, but surely we need to look at all the facilities to be able, that we should be able to do that for all the healthcare facilities, because essentially that's what we work with. We work with life and death of our people. And I'm also aware that, for example, in the Western Cape, it's also been implemented at regional hospitals and quaternary hospitals. So, honourable members, though, Honourable Minister, those are just a few points I wanted to raise. So many points had been raised. It's already 17 minutes past 12. I know we are not going to be able to receive answers to all of the questions raised in the time that has been allocated to us. We're looking forward to those responses, and we'll have to see how it goes by 1 o'clock and what other means can be used to maybe get some of those questions addressed. Thank you. Over to you, Minister.
Thank you very much. Thank you very much, Honourable Chair and Honourable Members. Indeed, I take cognizance of the fact that the time is not necessarily adequate. I had hoped that we would have at least a full hour, because our presentation did not take very long. We were done in an hour, but it's fine. Let me just, in terms of just a broad overview, and then I'll ask then the team. I'll ask members of the team just on each topic, just a high level. On the issue of vaccines, Dr. Crisp will come back and respond more specifically. But just, I think, Chair, you did try to create the context. But again, just to remind honourable members that, as I think at some stage, Honourable Sukers did comment on the fact, and Dr. Crisp did try to remind us where we come from. The fact that at the time when vaccines became available, first of all, as they were being trialed, as the trials were going on at the end of 2020, we had discussions with various of these manufacturers. Now, what they were looking for, even at that time, and which we couldn't really go into, was big amounts of millions of rands to pay upfront at the time when the vaccines were not even approved, the trials were not finished, and they were not approved by regulators of, in any part of the world. And some of the richer countries put down payments of billions of rand before even the vaccines were concluded. And we then entered into an agreement with the COVAX, which is a WHO coordinated facility, which was pulling together all the other, all the manufacturers, rather than a situation where we were expected to put down payment for each one of the various companies. We had meetings with Pfizer, we had meetings with Johnson & Johnson, AstraZeneca, and we had to after discussions with the Treasury, agree that we should rather, whatever we can put, we must put into COVAX. And also because of the manner in which our financial situation has to be worked upon, we also got a contribution from the Solidarity Fund to put some amount into the COVAX facility. Now, we had to put money into the COVAX because we don't qualify for a kind of subsidy by the WHO institutions, such as COVAX, because we are not rated as, although we are part of the middle to low income, we are not classified as the lowest of income countries, where facilities created by WHO and Gavi provide this, even not only just COVID, but other vaccines free of charge. We don't qualify for that, so we had to fork out some money also for COVAX. When it became possible to start to, where now the vaccines had been approved, unlike down payment during the time of trials, when they were now approved by various authorities, and they were also presenting to our own authority, which is SAPRA, for approval, we were then negotiating actual uptake. And I'm sure honorable members will be aware that at that stage, the pressure was really to say that we must acquire as much of vaccines as possible to cover what is required to acquire population immunity. And that population immunity was defined as 70% of the population. And in terms of 70%, and we then said, even if we don't go for initially looking at 40% of the population, which was then targeting 40 million, but we then said at least if we can be able to cover 70% of the adult population, then below the age of 18 can come much later. So we had to make provision whenever it was possible. We had to argue, we had to fight with the suppliers and try to make sure that we can make those provisions in terms of making sure that we are able to, to provide. But because already at the time, the richer countries had already started taking the big number of the vaccines, even as we finally got those agreements. Dr. Chris just mentioned the problems with the J&J, the issues at the factory in Baltimore and so on, and various other clinical issues which came in had to be cleared. But because richer countries had already taken the first place in the queue, we were pushed at the back of the queue. So even when we concluded in terms of that target of making sure that you can cover either a full 40% of the population or at least 40%, 70%, which was 40 million, or at least 70% of the adult population. So it was a responsibility on our side to make sure that that provision is made, and that's why we have this commitment currently. So in terms of then, at that stage, there was no way we could, none of us, whether even your top specialists, whoever you listen to, whether it's Professor Karim in the country, the gentleman from the US, I just forget the name, but all those specialists, whether it's Professor Mahdi in South Africa, Glenda Gray, and even internationally, all those specialists, none could, they could always just be a projection as to how the disease is going to progress, and therefore how long is it going to go, how much in terms of the pressure to, and the pressure was therefore to say, let's get the vaccines, let's make sure that as much of our population is covered. Of course, the down part of it is that as we got more and more vaccines, we got a good uptake around May, June, July, August. But once the severity of the disease started going down after the Delta, at the height of the Delta, the Delta wave, when really there was very high mortality and morbidity, we had a very good uptake. But as soon as the severity went down, the uptake then slowed down, and that is where we are at the current moment. And we have to then navigate around, but I can say clearly, even as Dr. Crisp is going to come and deal with all the vaccine issues, I can say clearly that the allegation that we have some other backhand deal with any of the companies, whether Bill Gates or somebody, that one is totally, unfounded. It's totally false. There's got no basis at all. We have put together whatever we do is public. We report to yourself as a committee. We report also to other, in terms of treasury, all those are done. We were also audited by the AG in terms of whatever purchases have been made. So there's no basis for any back deal. But again, let me just ask Chair that if we could ask Dr. Krip just to fill in on the vaccine issues. If I can then ask also Dr. Chris deal also with the monkeypox issues, and then we can then have Dr. Tulare just not a lot on the regulations. The only thing which I can say on the regulations is that in case there are major changes, it's we would not avoid raising the matters with the committee. We know that at the time when we had to put in emergency intervention, it was under the pressure of the control of COVID. We have lifted all those. Now we're working as normal in terms of amendment of regulations using those inputs. If indeed, as a result of those, and in terms of the advice, we'll be looking at the submissions, consulting also other experts, and even especially the World Health Organization will look at advisories in terms of that. If it does happen that there's going to be proposals and which we have to consider in terms of the final regulations, which go quite far beyond what currently exists, we will consider having a discussion with the committee in the case. But if it's a situation where there's not really, because of there's not much of any immediate threat and so on, there is no need for major deviation from what already exists, just minor changes from the submissions and also from other information. Then in that case, we may not necessarily have to come back, but I'm not closing the door in terms of the necessity if there's going to be major changes. Can I ask Dr. Cliff to come in if there's any addition, deal with both COVID and the monkeypox, and then Dr. Tulare will touch on anything which needs to add on the regulations, and Dr. Makanya, but also on just the capacity of the health services. DG would also come in, but also I'll also just ask the Deputy Minister if he has some areas where, after the officials have mentioned, where he might want to add. Let's start with Dr. Chris.
Thank you very much, Minister, and greetings again, Chair and colleagues. So I won't go over anything. I think the Minister's given very good context, so I'll just try and answer some of the specific questions. There was a question from Honourable Gela about how many vaccines expire in the next 2 months and what's their value. No vaccines are expiring in the next 2 months. Of the Pfizer vaccine, we have 3.9 million set to expire at the moment on the 31st of December and 4.7 million doses on the 31st of January. But as I indicated, we have an ongoing review of the stability of the vaccines, and those dates might still be pushed out on a rolling 3-month basis, which is not a decision we take. That is a decision that is made by SAHPRA based on the laboratory results from testing the vaccines. So at the moment, nothing is going to be destroyed. And there was also a comment, I can't remember who made it, about 1 million doses destroyed earlier in the year. None of those doses was destroyed. We were able to use all of the doses. So far, we have not destroyed any vaccines centrally. The only vaccines that get destroyed is the half-used or unused vials or damaged vials in the periphery at sites. Otherwise, no vaccine's been destroyed yet. The Minister has given the context about the vaccines. We have not placed an order for vaccines since the 21st of June, if I'm not mistaken, of last year. That was the last time any order for any vaccines was placed. The problem is, as Minister has explained, that we have commitments, and those commitments were made a very long time ago. The challenge is that we cannot get out of the commitments because of the nature and structure of them. I did try to explain that the COVAX facility, we have got out of a large part of it because the United States government made us a donation. We were given a credit for that donation against the vaccines we had not received from the COVAX facility. And with Johnson & Johnson, it's a different story. We have paid most of the vaccines. We have one invoice still to pay for vaccines that were ordered way back then. We have not received that vaccine yet because we've been deferring the deliveries. And that's the vaccine that we are trying to donate back to the WHO or to COVAX or to some other facility so that it doesn't go to waste. But we have not procured any vaccine. And also to add to what Honourable Minister said, any allegations that come out of staff members or anywhere else in the department, we have not placed any more orders, and we are not at this stage contemplating placing any orders for any vaccine, not Pfizer, not Johnson & Johnson, not Sinovac, Sinopharm, any of the other vaccines at this stage, because we have more than enough to manage with any potential upflare and even if there's a new surge. In terms of the notifications of cases, deaths, and so forth, I did put the link on in the chat of this group just so that honourable members can download it for themselves. And I'm sure the Secretariat of the meeting will also make it available to you. We did put out a notice some time ago, I don't remember the month, to say that we are only publishing figures once a week now and not daily. The reason for that is that the numbers are very, very small, and keeping our staff busy with daily updates when they should be focusing on other things is not seen to be valuable at this stage. But we monitor very closely, and whenever anything looks slightly different, we meet as a team with the NICD and we deal with it immediately. And so far, there hasn't been anything to be too concerned about. The question about chickenpox versus monkeypox, maybe I'll deal with monkeypox, chickenpox separately in a moment. Are we able to deal with another surge? Yes, we're definitely able to deal with another surge. We could reactivate pretty much everything that we had in place before. We now know how to do it. The routes of managing together is established. And are we using the clinics to vaccinate? Yes, very much. When I spoke in the presentation about integrating the vaccination into the primary healthcare system, that's exactly what we mean. There are some clinics that can't vaccinate and don't have the capabilities, but the vast majority do. And there's still a large number of private pharmacies, and there is a website where one can go to see who has vaccine at any one point in time. At the moment, most of the vaccine available that's distributed is Pfizer, as I indicated, 30,000 a month being distributed at the moment, and far fewer in Johnson & Johnson. When we bought the vaccine originally, we bought with the understanding we were going to vaccinate 41 million people, but only 23 million people have come for first dose, second dose, primary schedules, but also for boosters. So we have, at that stage, anticipated far more than we were going to use. There were questions about the loan. We're going to need to have a separate discussion with Treasury. Treasury will need to come and explain, because the loan is a Treasury negotiated loan. Departments don't negotiate loans directly, especially not foreign loans. There's a very specific procedure for loan negotiations facilitated by National Treasury. It's a retrospective loan. So we don't get involved in the technical details. We just have to report on what we are doing in the vaccination program from the health department. So I'm sure we'll have to deal with that in a different way. The MAC on social behavior specialists, so there was a whole Ministerial Advisory Committee, and maybe I didn't say it clearly. The Ministerial Advisory Committee members were not paid. Most of the meetings were done virtually. It's only very recently we've had a few face-to-face meetings. Even those members who are not public servants working in provincial departments or universities, even those who were working for other agencies, their time was all paid for by their employers or donated. We did not pay for the Ministerial Advisory Committees at the time during COVID. So the social behavior specialists who were involved in that, plus the linkages with the Human Sciences Research Council, the University of Johannesburg, the network through UCT, and others who were generating the social listening reports and working with us, were also working with the Government Communication Information Center, and we still work very closely with them. So very closely with all the other government departments. And I must also add that the private sector, both through the Solidarity Fund and through independent companies and other donors, contributed tremendously financially. So the cost of the programs for communication were largely borne out of budgets of other departments and other agencies. Doses expiring in December. What if the vaccines don't expire? So what are we doing to ensure that the vaccines don't expire? You can't ensure that vaccines don't expire. They will ultimately expire, but I tried to explain the laboratory work that goes on behind this. So there's repeated testing of samples of doses, whether they come into the country, whether they are manufactured here, whether they are bottled here, whether we want to change an expiry date. They all get sent to the National Control Laboratory, and there is a sample mechanism that complies with the World Health Organization standards, where they then come back to us and confirm or deny the application for an increase in expiry. But ultimately, all medicines and all biologicals do expire if you don't use them. Obviously, we would like to see more uptake, and that's why we are doing targeted interventions. We don't have the resources or the capability or the impacts that we would like to see doing mass, national media campaigns. But the targeted campaigns are bearing fruit, and that's why I was talking about the data that we use off the EVDS system and on the geographical information system, where we can target suburbs, villages, and so forth. We get better uptake where we do that. Regarding the adverse events following immunization, we have reported on this before. We can report on it on a separate occasion. That it was not asked for today, so I don't have the updated figures in front of me. But it is published on the SAHPRA website, because SAHPRA has the statutory responsibility for the monitoring of all adverse events, not only of vaccines, but of all pharmaceuticals, and they report globally. So the data is available. You can get it off the sub-website of SAHPRA, but there's no reason why we couldn't come and do a specific report on where we are with everything to do with that, including the no-fault compensation. How effective is our surveillance? In fact, South Africa's surveillance is amongst the best in the world. We're very proud of our surveillance. NICD plus the network of the various universities and other research associations who are also associated with universities has been lauded during COVID. And probably the reason for this is because of the immense effort and expense that's gone into setting up capabilities for HIV. So we have far greater capabilities than most countries have, and we use it very effectively. That does not mean there's not room for improvement, and there aren't plans to strengthen the integration of all the data that we use. That is ongoing, but we are not concerned that we will miss something obvious, or even if it's quite subtle. The development of vaccines, there is a process that is going on. It is led by the Department of Science and Innovation. There are a number of participating parties. I think the honorable members are aware that there's a WHO program, that we are part of a hub here in Southern Africa, and there are quite advanced initiatives for the development, for the technology development here in South Africa. And we do have the capabilities both in it's not quite a public company, but a partly owned public company, and in private companies for the fill and finish of vaccines. So once we are able to generate the raw product, we should be able to bottle without too much of a challenge. And it has been set up in a way that it's not just for COVID vaccine, but it's for all manner of vaccines that we would want to use in South Africa, both the existing types of vaccines plus others. So that is quite an exciting development. And obviously we participate. There's an interdepartmental forum where we participate with science and innovation on that. The story of 20 more doses coming. The story of vaccinating children. So SAHPRA, the SAHPRA has registered the vaccine for use in small children, age 5 to 11, but the VMAC has looked at the international literature and advised that there's no benefit in doing mass campaigns for children of that age. And the only children of that age who should be vaccinated with 1/3 of the adult dose, 10 micrograms instead of 30 micrograms, would be children who have immunocompromised conditions. And there's a very specific set of those. That will be controlled by pediatricians and general practitioners and other health practitioners who look after those children very specifically. And although the manufacturer would not like us to use fractionated doses, in other words, taking more doses out of the same vial, it is done in other countries, and we are going to use that as the process for vaccinating this small number of children who are at high risk. I want to emphasize no further agreements and no other vaccine orders since May 2021. So just very briefly then on some comments about monkeypox. First of all, to say that monkeypox is a different disease. It looks different from chickenpox, and I think the Honorable Chair has mentioned this. This is the season for chickenpox in South Africa, where the change of the seasons around August, September every year. Pediatricians and general practitioners see chickenpox. And these are children. This is a very different mode of spread compared with monkeypox, and it looks different clinically. So I'm not concerned that our clinicians don't know about this. Chickenpox is very common, and it's clinically diagnosed. It's quite straightforward in most instances, except in immunocompromised children where they may do further testing. As far as the awareness is concerned, the targeted audience interventions that we do includes webinars where we try and get to health practitioners as well as to interest groups and public groups. And there are guidance documents on the NICD website about monkeypox as well. I've sent to the secretary of the committee a link where honorable members hopefully can get hold of that link to find more information about monkeypox. It is notifiable in South Africa. Recently, it was added to Table 1, which is because it's something that's new and interesting in the world. We want to know about every case immediately. So Table 1 is the place where we notify the most and get the information the most urgently. So risk groups, there are risk groups in the monkeypox transmission, and there is a communication strategy that's outside of the normal mainstream media. The bulk are people who live in very close contact with one another, particularly men who have sex with men. So monkeypox is a very different mode of spread from chickenpox, where kids are in the same bed with one another and just transmit it to one another. In terms of vaccination for monkeypox, the WHO does not recommend mass vaccination and does recommend targeted strategies, but targeted strategies where there are concentrations of cases. And we've only had 5 cases, all not related to one another. So we don't meet the criteria for a vaccination in South Africa. We did have a discussion about whether to vaccinate laboratory workers and other people who handle specimens, but even that is not recommended by WHO. There are vaccines available in the world. We do not manufacture those vaccines. In South Africa, we are not likely to use them given the current spread that is going on and the fact that our cases are very well contained at the moment. But obviously, we remain open to that. That monkeypox vaccines are not registered by SAHPRA, so we'd have to bring them in batches for very specific cases. We have very good laboratory surveillance for monkeypox as well, and we do this laboratory surveillance for a number of other African countries, and through with the WHO and CDC, we do a lot of the specimens for them as well. So I think that those were the main questions I was asked to respond to. I hope that's adequate. Thank you.
Thank you very much, Dr. Crisp. Can we get Dr. Tulare if there's anything you want to add on the regulations process? Dr. Tulare?
Thank you, Honorable Minister. I just want to provide...
just as you come in, I had some members calling you Dr. Tulane. It's Tulare, not Tulane. Tulane is a name of a man. This is Tulare, as it's shown there. Thank you very much, Dr. Tulare.
Thank you, Honorable Minister, and thank you for that correction. I'm going to provide a few responses, not so many, Honorable Minister and Honorable Chair, Honorable Members. My first response is to Honorable Gela, who asked what the potential costs of the regulations are. In general, when regulations are passed, we look at implementation costs, we look at costs associated with compliance, and we look at infrastructure costs. And lastly, we also look at costs related to a communication strategy that must be used to popularize the regulations and make sure that they are mainstreamed. Just to indicate that in terms of implementation costs, if you look at some of the regulations like port health, we may have to increase our number of port health officers that are going to oversee the implementation of the regulations. In terms of notifiable medical conditions, we do not anticipate any implementation costs in that area. And in terms of, for example, on mortal remains, how mortal remains are managed by funeral undertakers, those costs are not going to be directly related to government or the regulator, but they are going to be related to those that are being regulated, such as funeral undertakers, who must ensure that their infrastructure meets certain standards that are required in terms of their funeral parlors. And then in terms of compliance costs, currently with the current dispensation of regulations like those that were published in 2017, the certificate of competency or compliance is issued free, so there are no costs. But all this will be captured in the final revised socioeconomic impact assessment study report that I had indicated earlier in the presentation that the Department of Planning, Monitoring and Evaluation is still looking at together with the department to make sure that there's alignment and it's compliant with the requirements. In terms of the questions that were raised by Honorable Clark, Honorable Van Staden, and Honorable Ismail on how many people are opposed to the regulations, we want to report that at this stage, we are still looking at all the regulations that I had indicated are just under 400,000, and we are not in a position to report to Parliament at this stage how many people had opposition or objection to the regulations. Honorable Clark asked about a report that was made that the department had deleted submissions from the public. Just want to clarify that there was no deletion per se of these submissions, but what had happened is that when the initial set of regulations were published, names of officials in the department were provided as the people who will receive the comments. The department subsequently created a main system, a lake that was going to accommodate all the regulations because the number of regulations, the number of comments that were coming in were clogging the system and preventing officials from doing their day-to-day activity. So we created this lake and we transferred the comments from the individual emails into this lake. And so all the submissions that were received were transferred into this lake. And it might have appeared that once the transfer had taken place, there was deletion, but actually they were not deleted per se, but they were moved into the big pool of platform that we are using to assess all the submissions. So we just wanted to assure honorable members that there was no deletion in this regard. And so I think, Honorable Minister, that is all that I wanted to respond to. Minister has already indicated that if ever there is major changes to the regulations as published, he is amenable to a process where Parliament will be appraised of what the changes are. I thank you, Honorable Chair, honorable members.
Thank you very much, Dr. Tulare. Also, just on that point, just to assure Honorable Wilson and Honorable Clark that we don't have any leeway in terms of going against the Constitution. Honorable Wilson was worried about transgressing Section 27, the Bill of Rights. All legislation has to be, well, first of all, here we're not even talking about legislation, we're talking about regulations, which must comply with the primary legislation, and the legislation itself must be constitutional. So we're all conscious of that. And in case something wrong happens, as we know, the constitutional, our court systems are there to oversee if anything goes wrong in terms of constitutionality and respect of the Bill of Rights. Can I get Dr. Makanya? There were issues around the waiting time, all these periods the validity of the stats which is being provided by provinces. Do you want to maybe have comments on that? As you finish, I would want to invite DG also. There are issues around which Dr. Makanya could touch on. How do we increase the staff, the theater nurses, the registrars, the specialists, the ComServe, they're looking at all our dispensation in terms of ability to can have more resources to deal with many of these challenges on the human resource side. But Dr. Makanya first, and if DG could be ready to fill in where it might be necessary. DG also backlog on TB and HIV as a result of the COVID pandemic. If you could be ready to add on that. Dr. Makanya?
Thanks, Honorable Minister. And I would start with a question that acknowledging the accuracy of the data that has been provided. We have indicated that this record reflects data that has been provided by the provinces during the period of June and August this year. And it's a reflection of how the dealing with the backlog has been such a moving target. It would happen that the response that was provided earlier to the honorable member reflected different numbers, and we acknowledge that. But it's also an indication that the list is getting updated as we see that the number that we are reflecting now is different from the number that has been provided previously. But I also would want to say that that's what one would say regarding the accuracy of stats. We agree with that. It's based on the work that the provinces are doing. And if we look at the drives that provinces are doing on weekends, we have not had any update since August in terms of the difference in dealing with the backlog. However, we note that the provinces did not give us an indication of within which time frame they are actually planning to eradicate the backlog, and that is what we would be making a follow-up as we get as we continue to get information in terms of managing backlog. However, we're also encouraged that most provinces have centralized information system that actually makes them monitor from a tertiary level system in terms of the progress with managing of the backlogs, with management of backlogs. And the increase of probably also to indicate that the work on backlogs is being done concurrently. There are various slates that are going ahead concurrently. There is a slate of new emergencies, and this plan include plans that are in place in terms of dedicated theaters and dedicated staff to deal with new emergencies that get to happen at any given time. There is also the plan also there's also work that is doing with elective surgeries that are also getting to be booked in the context of dealing with the backlog. And there's also dedicated effort in terms of putting systems and infrastructure that is required to deal with the electives. And in addition, what we're presenting is that over and above the emergencies, the elective, then there is a dedicated effort of actually reducing the backlog. So new emergencies are not compromised, or new emergencies and electives are not compromised or competing for the same resources with the backlogs that we have alluded to. And if you look at the other question related to the increase of theater nurses, and probably just to look at theater nurses in particular and probably broader HR requirements. All provinces in the face of budget cuts have actually reprioritized, have actually looked at how they would reprioritize their budget for COE, and the reprioritization is based on the demands for service delivery And for instance, in terms of areas of critical or specialized care is required. So when post arises, those are prioritized in terms of being filled when post arises in provinces. In terms of dealing with theater nurses in particular, from the training point, we still have a pipeline of about 5,000 nurses. There are 500 nurses who are qualified on specialists that get into the system with an obligation of serving back the system, hence guaranteed or contributing to boosting up some of the HR related to specialized care. And within the department, there is also dedicated grants that look into health professional development, and that grant is actually used to prioritize appointment of clinical specialists, be it doctors or nurses that are working in specialized areas, and that would cover the HR needs for theaters. So probably that is what one would highlight in terms of increasing the clinicians that are required. Linked to the equipment of theater equipment, again, there are dedicated grants that had to be rearranged, that needed to be rearranged to be able to make sure that high-end equipment that is required to deal with the backlog is prioritized, and that grant is complementing the resources that provinces have on their own. And nationally, we are also assisting and contributing to getting appropriate equipment. And again, there is a 5-year maintenance, 10-year maintenance plan in the department that is also aligned to the needs at provinces, and that really looks at the needs of the provinces, like we have seen some of the provinces prioritizing maintenance and replacement of equipment that are in theater, like autoclave and like autoclave that has been highlighted. In areas where there is still dire need, there was also—
Can you round up, Dr. Makanya? I see the time of the committee is running out, please.
Okay. Thanks, Minister. And probably I would like to comment around the initiative of ComServe. We need to indicate that the department has deliberately made sure that when we were appointing contract workers to manage COVID, our product, which was ComServe, are always prioritized in that regard. And as those contracts, it's an added effort of making sure that they get to be prioritized in addition to prioritizing them for appointment for those posts that become available. Thanks, Minister.
Thank you very much, DG. A word from you also on the human resource and other things which you may want to comment on.
Yes, thank you very much, Minister. I think most has been covered, but just to say that we are equally concerned on the issue of the surgical backlogs. What we've decided to do, we've picked up some best practices. Last week we did meet with all the HODs. For example, in the Northern Cape, they've come up with some innovation where they've cut the waiting list for oncology to actually almost 7 days, because they've come up with that, and we've presented this. We now want to roll this one out throughout the provinces. The second one is this weekend blitz that are done mainly in Limpopo and in KwaZulu-Natal, where they can do more than almost 100 cataracts over the weekend, more than 30 surgeries. Again, we're pulling this together and we want to try and replicate them in other provinces. But then, of course, they just back up in terms of the work that we need to do. We are working hard to ensure that we pull together staff so that hospitals function properly. We have a minister, as my last shot, the issue of TB and HIV recovery plans that have been launched, and it's moving quite very well, and we are picking up in terms of the statistics and all the work that we lost. And as a last, I've just got a call. We're meeting tomorrow with the ESCOM generation, with all the provincial managers and the HODs, just to ensure that what has currently happened in Gauteng is rolled out in other provinces, and we are very positive about that. Thank you very much, Minister. I'm just worried about time.
Thank you very much, Deputy Minister Dinangwa. I'm sure your former colleagues want to hear from you.
Also concerned about time, but thank you for giving me this opportunity. I was only going to comment to what Honorable Wilson and Honorable Clark has raised, but also taking what Ahmed Sheikh mentioned, Honorable Ahmed Sheikh, to say what can we do collectively to support the department? It's just to share with the members that from our experience, when we have the issues of specialists, none of our specialists are trained outside the public hospitals. There was an arrangement where we noticed that in KwaZulu-Natal alone, when we were running short of oncologists and had not a single oncology available to support us, there were 60 oncologists that were on a private space. Some of them would actually complete their work today and move on to be specialists the next day. So maybe members could actually say, is there a possibility of working together and supporting the department, even if you are on private, and give your time, your theater, your skill for the very same institution that has trained you and produced you, and those patients who have produced and given you that skill of being a specialist? Thanks, Honorable Minister, and thanks to the members.
Thank you very much, Chair. I know your time is over. Just as we conclude, just to assure the honourable members that with the downward trend on the pressure of COVID, we are really trying to claw back on the issue of quality, working with the provinces, supporting them, identifying various areas. And that's why, for instance, even urgently on the issue of the electricity now, we put it as a high priority with the very tight time frames to try and make sure that that can be alleviated. But we're looking at the issues of infrastructure, issues of equipment, making sure that the conditional grants, which are also which provinces have to supply us with business plans, and making use of all those instruments, working with the provinces to address the issues which members are concerned about in terms of the quality of service. But I want to also just close by saying that, contrary to what honourable members like Honourable Van Staden think, that rather than even talk about the NHI, we should just focus on the improvement. As far as we are concerned, the two go together. The more, just as we've learned the lessons in terms of dealing with the vaccination program, other aspects of COVID, the more we can bring together a more unified system of funding and service provision, the better, which is what the NHI is trying to do. So we're not waiting for the legislation, the things which can be done, which can bring better service. We're working with our colleagues to try and make sure we give that support and guidance. But at the same time, we believe our system is fundamentally wrong. Even most advanced countries, many of the most advanced countries have come to terms that health should not be a commodity, which must be on the basis of affordability, but it must be a public good. And we strongly believe that until we move towards that, and of where health becomes a public good and all resources are pulled together, we're not going to be able to totally solve all our issues. So the two, in our view, is not either or. Thank you very much, Honourable Chair. Back to you, Chairperson. You are muted.
Oh, thank you very much, Minister. I was about to just thank you in the department. Now I see a hand raised of Honourable Clark. Honourable Clark, I hope it's a very short item because we are at 1:06, and I'm not going to take any other hand after your hand now, Honourable Clark. I'm going to give you this opportunity, but I hope it's very short. Please
Thank you,
proceed.
Chairperson. And I think it's an extremely issue and it will take a very short, quick input. I would just like to raise with the Minister the issue that happened in the Eastern Cape yesterday, where a 15-year-old girl was gang raped and taken to a clinic at Motherwell, was referred away from that clinic and died at the local police station. And I think, it's really a heart-wrenching story, this, Chair. When I read that article, I was in tears, and I think the Minister really needs to take cognizance of this matter. And thank you for allowing me to raise this issue at our meeting today. Thank you, Chair.
Thank you very much, Honourable Clerk. I'm sure the Minister takes note of what you're raising. And we're still in a very bad position with regards to gender-based violence and abuse of our younger female compatriots and all female compatriots in our country. And it's something that we all are very concerned about and that government is seized with. And we should all just raise our banners to support any initiatives which will bring such things to an end. So thank you very much. Honourable Minister, thank you very much to you and the department for coming today and bringing us these presentations. Of course, we know that the work is ongoing and it's a work that would never end because we deal here with human beings and we deal with the, as I called it earlier, life and death of human beings. But the care of people and the needs of people. And you're correct to say that every person has the right to access to quality health care, regardless of their ability to be able to afford health care. So in that context, also in terms of the improved systems that you're looking at and the improvements which are made within the National Department of Health, and also your provincial counterparts, we look forward to seeing more of those improvements and to seeing more of those engagements. We want to certainly have further engagements with you and the department again. With that having been said, thank you very much again. Our meeting is then closed, members.
Thank you very much, Chairperson.
Thank you, Chair.
Thank you.
Thank you, sir.
Thank you, Chair.